Hello and welcome to this lecture. Today we are going to discuss the antagonist of adrenocortical agents, and let's discuss synthetic inhibitors of glucocorticoids antagonist. So the drug we have is aminoglutethimide, and they block the conversion of cholesterol to pregnenolone, and they use in conjugation with dexamethasone or hydrocortisone to reduce or elimination of estrogen production with carcinoma of the breast. So first of all, you have to understand that what this classification of drugs do. As the name indicates, these are antagonists of adrenocortical agents. And antagonist, what is the meaning of antagonist? They are blocking the action of adrenocortical hormones. And in this case, we are discussing the first classification, which is synthetic inhibitors. And in that case, that we are discussing aminoglucothiamide, and they are actually trying to reduce the elimination of estrogen. As if you studied pathology or if you have familiar with the carcinoma of the breast, we will discuss actually in detail in chemotherapy. So what these drugs are do, they are trying to reduce the estrogen production. And what is the function of estrogen? Estrogen are responsible for causing breast cancer. So if there is an increase of the estrogen production, then there will be more risk for breast cancer. And these drugs are reducing the estrogen production to reduce the chances or reduce the risk of breast cancer. The recommended dose is 1 gram per day. Aminoglucothiamide is used with metoprolol or ketoconazole. Also, it is used in combination to reduce the steroid secretions in patients having Cushing syndrome due to adrenocortical cancers which do not respond to mitotin. So actually, in generally, these drugs are actually using for either for the treatment or reducing the risk of the breast cancer, or it can be used for decreasing the secretions, because they are known as antagonists. So they are reducing the effect, they are blocking the adrenotropic hormones, adrenocortical hormones, and they are talking about in this case that patient having Cushing syndrome can be treated with these drugs, and they are using with the drug in combination in either with ketoconazole or metoprolol. But if they do not respond in case of mitotin. Ketoconazole is also a potent non-selective inhibitor of adrenal and gonadal steroid synthesis, and they are also responsible for inhibition of cholesterol. But the main thing you have to memorize or you have to understand that cholesterol or, for example, high density lipoproteins are responsible for the synthesis of adrenal steroids. So if a person having high density lipoproteins, HDL, or high cholesterol levels, then there will be more production of the hormones, steroid hormones. And what these drugs are doing, actually, these drugs are blocking or inhibiting the synthesis of cholesterol. As they mentioned in ketoconazole, they are inhibiting the synthesis of cholesterol. And if you take a look on the previous point as well, they also mentioned that aminoglucothiamide block the conversion of cholesterol to pregnenolone, which is a key step for the synthesis of estrogen. So you can see that this is so how they work and their mechanism work. And they also use for patients with Cushing syndrome due to several reasons. We are not going to discuss the reasons behind. The dose is recommended is 200 to 1200 milligram in a day. The drug that is available in the market is ketoconazole. It is available with a number of commercial brands. The initial recommended dose is 400 to 600 milligram daily, with an increase of 200 milligram increment every 7 to 28 days if tolerated. It is very important. A maximum dose that is recommended is 1200 milligram daily, and all doses are given in 2 to 3 divided dose. And the key point must be understand that the dose reduction or dose discontinuation may required time. Patient cannot stop the dose or the drug immediately, and it also depends upon patient adrenal and liver function. So we need to test the liver function and adrenal function before stopping the drug, and this is a very important point. Then we have the other drug, which is metoprolol. And metoprolol is a relatively selective inhibitor of steroid 11 hydroxylation, interfering with cortisone and corticosterone synthesis. We're not going to discuss this block mechanism of action. We're not going to discuss the flow diagram, how the conversion occurs, but I am just going to go just a brief that cholesterol is converted with cholesterol is converted into pregnenolone. Then with the help of enzyme, it converted into progesterone. With the help, and then with the help of another enzyme, it converted into 11-deoxycorticosterones. And 11-deoxycorticosterone, in the presence of different enzymes, converted into corticosterones, which then produce aldosterones. So you have to understand that the cholesterol, in short, the cholesterol is responsible for the production of aldosterones and corticosterones. So you don't need to see the mechanism, as we discussed them in another lecture. So what actually these drugs are doing? The main thing these drugs are doing, that they are the selective inhibitor of steroid 11 hydroxylation, and this is 11 hydroxylation. So they are inhibiting this step. So by inhibiting this step, or by stopping the production of the enzyme 11 beta hydroxylation, the aldosterone production will be stopped. So that is why they interfere the synthesis of corticosterone. That's why they are talking about that. Then, but the toxicity is much lower than the mitotane. Mitotane is another drug under this classification, but the toxicity of this drug is lower than mitotane, which is considered as only dizziness and gastrointestinal disturbance. Metoprolol is also used for the treatment of Cushing syndrome, especially in pregnant women. It is also used to test the adrenal functions. So the test which is used is metoprolol stimulation test to detect the partial defects in pituitary, adrenocorticotropic secretions. It is also used for the test of pituitary functions, and the dose usually given is 2 to 3 gram orally at midnight, and measuring the ACTH level or 11-deoxycortisol level in the blood in the morning around 8 a.m. and by comparing the secretions of 17 hydroxycorticosteroids in the urine during a 24 hours period and following administration of the drug. Then the next drug is mifepristone, and it is used for contraceptive congestive agent in abnormal pregnancy or termination of pregnancy 49 days or less. High dose of mifepristone exert anti-glucocorticoid activity by blocking the glucocorticoid receptors. The half-life of drug is 20 hours. Currently, it is used for inoperable patients with degenerative or atopic ACTH secretions, or because of the adrenal carcinoma, who fail to respond to other therapeutic drugs. So the drug is used commercially. The dose is required is 30 milligram per kg at midnight, with a maximum dose of 3 gram is allowed, especially for diagnostic purposes to differentiate pituitary or ectopic production of ACTH in patient with patient having ACTH dependent Cushing syndrome. So it is used for diagnostic purposes, and it is also used for patient having Cushing syndrome around 250 milligram to 6,000 milligram daily in divided dose according to the patient requirement. Then the other classification in antagonists of adrenocortical agents are mineralocorticoids antagonist, mineralocorticoid antagonist, and a common example is spironolactone, which is also used for the treatment of primary aldosteronism. The dose is recommended is 50 to 100 milligram per day. And aldosteronism in hypokalemia patient having low potassium level with hypertension, the recommended dose is 400 to 500 milligram per day for 4 to 8 days with adequate intake of sodium and potassium. The other commercial available preparations are mitotane, and mitotane is used for the treatment of inoperable adrenocortical tumors or Cushing syndrome. So thank you so much for today's lecture. Hope to see you again.